Hello and welcome to our next episode of Clinical Conversations provided by the Royal College of Physicians, Edinburgh, Trainees and Members Committee. My name is Anda Balarga and I'm currently a T&MC member. Today I'm delighted to be joined by Dr. Colin Stirrat, Consultant Cardiologist at the Royal Infirmary of Edinburgh. Welcome Dr. Stirrat and thank you very much for your time.
Thank you for inviting me.
Thank you. Dr. Stirrat has a specialist interest in electrophysiology and device therapy, and today we're going to talk about atrial fibrillation. And really we're going to cover what's new in the clinical assessment and management of AF patients following the recently updated guidelines on AF from the European Society of Cardiology. As we all know, atrial fibrillation is the most common sustained arrhythmia and is often encountered in medical practice. It is a topic relevant to all medical practitioners, irrespective of specialty or clinical setting. So before we start, I thought I'm going to ask you, Dr. Stirrat, to give us an overview of the key updates from the recent guidelines that you think are important for clinical practice or will change the way we look after AF patients.
Well, Anda, firstly, thank you very much for inviting me to come and talk to you today about atrial fibrillation. The guidelines that have been developed recently advocate a more personalised approach to AF care, integrating a holistic approach and really involving patients in the decision-making process. There are several key updates that hopefully we'll be able to cover in our discussion this afternoon. So firstly, the ESC have proposed a so-called ABC pathway. Now, I really like this, and it's a simple reminder of the key factors in treating patients with AF, and it also allows for this personalised approach. So what is this ABC pathway? Well, firstly, the A stands for anticoagulation. So we have to consider all patients whether they should be anticoagulated or not to avoid stroke. And the decision regarding anticoagulation is according to the CHA2DS2-VASc score as before, so that part hasn't really changed. So what about B? So B stands for better symptom control. Now this could be rate control, or it could be rhythm control with medication, or even catheter ablation. So it's really whatever improves the patient's symptoms. So what about C? And this is the part that I really like actually. C stands for cardiovascular risk factors, or AF, with an emphasis on risk factor modification. Now the reason that I really like this, well, I'm an electrophysiologist who sees patients referred for specific treatments for atrial fibrillation, and I'm just really delighted that ESC has emphasised the importance of early risk factor modification for atrial fibrillation. There are some other updated recommendations for screening, some new recommendations for catheter ablation and for patients undergoing PCI. Hopefully we'll get a chance to cover most of the important points this afternoon.
Great. I think that's a great summary. Thank you so much. And yes, they've made some important, changes or highlights in the care of AF patients, and we'll cover some of these management issues in more detail. But for the first part, because you said you really liked C, and I think risk factor is so important in the management of AF patients. Can we summarize a bit the etiology of AF? We know it's multifactorial. And the recognition of risk factors and comorbidity optimization is an important aspect of the ABC AF care pathway. What are these main risk factors that we should be aware of and should be managing?
So clinical risk factors are really important, and they're something that we've kind of ignored until the last sort of 5 or so years. We'd always looked at atrial fibrillation, or previously historically looked at atrial fibrillation as more of a primary rhythm disorder, which it is. But for many patients, and probably the vast majority of patients that I see, in Edinburgh, the AF has generally happened for a reason. Now that can be things like genetics, but for the vast majority of people that I see, there are clinical risk factors that that are important in them developing atrial fibrillation. Specifically, I think there's some really good evidence that losing weight in patients carrying excess weight significantly reduces their AF burden. Other modifiable risk factors include hypertension, diabetes, hyperlipidemia, sedentary lifestyle, smoking, excess alcohol, and these kind of things. Now, these are the things that really provoke atrial disease or atrial muscle disease, with fatty infiltration, with fibrotic infiltration, atrial stretch, atrial dilatation. Now, all these things that cause somebody to develop atrial fibrillation. I thought I'd maybe just touch upon a couple of more specific points and emphasize the importance of weight loss and modifying risk factors, because I think this is really important. So I mentioned that I'm referred patients for catheter ablation for AF. Now, catheter ablation is a good treatment, but it's certainly not perfect. And I think some of the success rates are often overemphasized to patients. So for an example, if you've got a patient with paroxysmal AF, I would say for most patients, we would quote them something like a 70 to 80% success rate, that being freedom from AF at about a year, and that's for paroxysmal AF patients. And for persistent AF patients, it's probably more in the region of 50 to 60%. The success rate of these procedures has to be weighed up against the risks of a procedural complication. For AF, for a catheter AF procedure, serious and life-threatening complications are pretty rare, less than 1%, but complications can be serious and include things like stroke, tamponade, atrioesophageal fistula, and phrenic nerve palsy. So I'm slowly getting to my point. But if you have a patient who can significantly reduce his or her AF burden with weight loss, modifying other risk factors, perhaps alongside an antiarrhythmic drug if tolerated, their symptoms might improve substantially to a point where the patient feels better and that catheter ablation is no longer warranted or justified. So I think the importance of modifying risk factors for AF really shouldn't be underestimated, and I'm delighted that the AF have included this in the ABC approach.
Yeah, so you're basically saying that when someone has AF diagnosed, then we should really, in that first instance, consider all these risk factors and try and address them. The same basically would be doing with people with cerebrovascular disease or ischemic heart disease, and address them well, and of course discuss management options as well, but address that risk together with stroke risk and other things, because they all come in together.
Yes, you've summed that up really well.
Yeah.
I didn't.
And so that kind of makes me think, though, because AF is common, isn't it? What about screening, especially opportunistic screening in patients who have risk factors such as hypertension, smoking, obesity, as you said? What about that? Do we need to do it? What's your thoughts on that?
Well, screening is, has its pros and cons. Screening for any condition has its pros or cons. And there is an update on screening in the guidelines. So for AF, the aim of the screening is to identify people who might benefit from anticoagulation, who we may be able to prevent a stroke for by giving them anticoagulation. But on the other hand, screening may simply just involve checking a pulse, but may involve doing an ECG, and we may cause the patient to be quite anxious about that, or we may find things like structural cardiomyopathies or channelopathies or things like that, which the patient didn't know about before. So I think we have to think about that when we start any kind of screening process. Mm-hmm. The EAC say that we should opportunistically screen elderly patients, so over 65, by a pulse check, but then go on and confirm this by a 12-lead ECG, and that we should also be screening cardiac devices, so pacemakers and ICDs. But they've advised us and reminded us that we really need to fully inform patients about the pros and cons of entering into a screening program. They've also suggested that although opportunistic screening is good and it's cost effective, obviously the diagnosis needs confirmed on a 12-lead ECG or a single lead ECG for at least 30 seconds. I think screening is going to change a lot over the next few years, and we've got devices such as smartphone apps or smartwatches that are now capable of detecting AF and are becoming common and mainstream, and patients are starting to self-present with really self-diagnosed AF, whether it be symptomatic or not, or asymptomatic. And I think this really is a fast moving area at the moment. So I would watch this space, if you excuse the pun.
Yes.
But I think we need to be very careful in ensuring that all these devices, smartwatches, smartphones, are accurate, and then AF is confirmed by another means. Just comment on asymptomatic AF. Some previous screening studies have identified 1 to 2% of the elderly population to have previously undiagnosed AF or asymptomatic AF, which appears to have a worse outlook than symptomatic AF. But this may well be related to other comorbidities that make them asymptomatic in the first place. So I think screening, yes, opportunistic screening is cheap, cost effective, but I think we need to be careful about screening programs, and this area is going to change considerably over the next few years. And I'm beginning to see a lot of patients with health anxieties because they've bought a smartwatch, or they've been watching their pulse on their smartphone or whatever. So I think we're going to need to think about this and have clearer guidelines and protocols about this going forward.
Thank you. That is excellent advice. That was my next question. I was going to ask you about wearable devices, but I think we covered that. And as you said, and as the guidelines say, involving the patient in terms of deciding the risk of benefit of this is important. Mm-hmm. If we go back to the patients that we see on the medical wards, or considered referring for specialist investigation, can we summarise what are the standard investigations that should be performed in all patients with newly diagnosed atrial fibrillation? And should all patients be referred for an echocardiogram or cardiology specialist assessment?
That's a really good question, and I think what was the standard of care a year ago, with the current COVID climate, might not be the standard of care now. Or certainly, COVID's led us to review how we approach different clinical scenarios. In terms of tests, so let me start with tests first. I think it's useful to take standard blood tests. Blood count to check the patient's not anemic, renal function, liver function, TFTs. I think these are all pretty important things you want to check. The patient wasn't hyperthyroid, for example. Renal and liver function are important bleeding risk factors, including the Has bled score. You obviously want to check the patient wasn't particularly anemic or had iron deficiency anemia before you anticoagulated them. And obviously, renal function dictates what dose of oral anticoagulant you use. For some of the oral anticoagulants, the dose does change based on renal function, or whether you can give an oral anticoagulant at all, dependent on the renal function. So I think these are sort of mandatory tests, I would say. The echo question is is a good one. I think we really need to look at our resource use at the moment. So I would say I don't think an echo is mandatory for all patients, but I would qualify that with it's very useful in the vast majority of patients. If you have an elderly patient where you're accepting a rate control and anticoagulation strategy, who, for example, doesn't have any murmurs or no signs of symptoms of heart failure, a narrow QRS duration in the ECG, and I don't think an echo is mandatory if that patient, symptoms are controlled or anticoagulated or rate controlled. On the flip side of that is if you have any patient who you're pursuing a rhythm control strategy, say, a young patient or any patient with a murmur or signs or symptoms of heart failure, then yes, I think an echo is absolutely warranted. You'd obviously want to check LV function is normal before giving any common antiarrhythmic, such as dronedrone or flecainide. You also, I think you asked me about
yes.
specialist assessment.
Yeah, cardiology clinic.
Well, I think that depends on the experience of the attending physician. Many GPs or some GPs will be quite comfortable in starting anticoagulation and ensuring rate control, for example, in patients found opportunistically to have AF. If these patients are truly asymptomatic, providing the GPs looked at the ABC, then I don't think the patient necessarily requires referral. So say an elderly patient, opportunistically screened, asymptomatic AF, rate controlled, no symptoms, they've been considered for anticoagulation, then I don't necessarily think they need to see a specialist. I would say that I would suggest referral for all patients who remain symptomatic despite initial treatment, especially patients suitable for a rhythm control strategy, and especially young patients. This isn't in the guidelines, but there is some emerging evidence that a more aggressive and earlier rhythm control strategy may be beneficial. And so I think, certainly younger patients eligible for a rhythm control strategy, then yes, I think refer early.
Great. So I think that the same theme kind of is emerging, isn't it? The personalised approach to assessing these patients.
Yeah.
So we talked a bit about the assessment, the risk factors, and at the beginning you summarised nicely the ABC management pathway proposed by ESC. So I'm just going to summarise that again, and hopefully we can just go through some specific aspects for each point. So A stands for anticoagulation and avoid stroke. B is for better symptom management, and C for cardiovascular and comorbidity optimization.
Yes, that's right.
Are there any changes in the assessment of stroke risk and prevention, or the risk of bleeding? You said already, I think, about CHA2DS2 and has bled, and is that the same? Have there been any?
No, there's not really been changes on that regard. No, so the CHA2DS2 risk score is still used. So males with a score of 2 or greater, females 3 or greater should be anticoagulated. Males with score 0 and females with score 0 or 1 don't need to be anticoagulated. And for the sort of group in the middle, so that would be males with a score of 1 and females of 2, and the ESC say that anticoagulation should be considered. The has bled score, so the bleeding risk score that we've been using, hasn't changed either, although there is often a little bit of confusion about the use of the bleeding risk score. And I would emphasize that the has bled score isn't there to prevent or deter us from prescribing anticoagulation. It's really, it comes down to this personalized approach again, but it's really to identify those at high bleeding risk so that it really gives us an opportunity to modify any bleeding risk factors and to ensure these patients at high bleeding risk have a regular evaluation of their bleeding risk factors. I'd also comment that I get asked quite a lot about falls risk. The ESC are pretty clear about this. They said that a risk of falling or patients that fall shouldn't really deter physicians from prescribing an oral anticoagulant to patients who are eligible for an anticoagulated and whom it should be recommended.
Yeah. And specific question about anticoagulants. So the direct oral anticoagulant therapy is preferred now in the management of stroke risk in AF patients over vitamin K antagonists such as warfarin. Of course, with some exceptions there, like prosthetic valves. However, we do have patients who have been on warfarin for a long time. What is the practice or best practice there? Is it to switch them to a NOAC, or is it to leave them on a warfarin if they manage okay with the INR checks and everything is fine?
Yeah, we still see some patients who are on warfarin for AF, but I think we all know, and as you mentioned, that an oral anticoagulant is better. I think the trials all tell us that, and we're pretty comfortable about that now. But what about patients stable on warfarin? Well, I think if they've got a very high proportion of time within the therapeutic range, so they're within the therapeutic range, the vast majority of the time, then I think it's not unreasonable to keep them on warfarin. I think you'd obviously involve the patient in this discussion, and some patients don't like the sound of an oral anticoagulant or whatever. They've had a friend or a relative that's had a bad experience. So I think patient preference is important here. So for these patients, I don't think it's unreasonable to keep them on warfarin. However, in the current circumstances with COVID, we're taking the opportunity to look at how we are delivering healthcare, and I think we're trying to essentially limit, certainly at the moment, face-to-face contact or unnecessary face-to-face contact to try and reduce the COVID spread. So I think switching AF patients from warfarin to an oral anticoagulant, where they wouldn't need to see a healthcare professional so often for an INR check, it seems like a bit of a no-brainer to me, that these patients could, maybe should be switched. The ESC, I don't think say that. I think they say you can keep patients on warfarin if their time within the therapeutic range, is satisfactory.
Yeah, that's a good point. So the last few months are definitely changing the way we provide healthcare. So if we think about B and the symptom and better symptom control, what is the recommended approach to managing symptomatic patients with AF who are hemodynamically stable, and what's the preferred first-line therapy?
I think if we go, I think we will always start with the ABC approach. So for any symptomatic patient, we'd always start with A. For any patient, we always start with A. Consider anticoagulation. But what about symptomatic patients? Well, some symptomatic patients may simply be improved with rate control, perhaps elderly patients, or patients in whom a rate control is more sensible, or a rhythm control strategy perhaps isn't sensible. In terms of rhythm control drugs, which is I think what you were sort of getting at, there really isn't a go-to drug for all situations. So how do I choose a drug for a specific situation? Well, it really depends on the clinical characteristics of the patient, and of course patient preference, as is a theme through this discussion. The first line antiarrhythmic drugs that I tend to use more of are flecainide, usually along with an AV nodal blocking drug, because flecainide can organize atrial fibrillation into a kind of a slower flutter rhythm, and in patients with quite quick AV nodal conduction, maybe in young patients, they can conduct flutter one-to-one to the ventricles. So I would usually prescribe this along with an AV nodal blocking drug. The other antiarrhythmic that I use quite often for AF is dronedarone. Now, both of these tablets have their pluses and their minuses. So I guess flecainide can be used as a pill in the pocket approach, so just infrequently for patients who get an AF infrequently or who don't want to take regular therapy. But in terms of flecainide and dronedarone, well, dronedarone's got its downsides. It needs to have monitoring for liver and renal function. Both of these tablets, flecainide and dronedarone, you wouldn't give to somebody with significant LV impairment. So there are things that you need to consider, and obviously patient preference as well.
And you didn't really mention amiodarone. Sorry to interrupt you. Is that
no. Well, sorry, what was the question?
You didn't mention amiodarone in the rhythm.
Yeah, I wouldn't give amiodarone long term to patients usually, especially if they're young, due to the risk of the long term side effects. I would, however, and I do often give it to elderly patients because you're less worried about the long term side effects in someone who's in their 80s, especially if they're highly symptomatic from AF. The other time I use AF quite a lot is when I'm cardioverting people. So when you're planning to use it on a short term basis, so I use it to try and enhance the chances of a successful cardioversion. And I know some people use it around the time of catheter ablation to try, it's really our most powerful antiarrhythmic AF drug that we use. So I think short-term use is okay, but I wouldn't use it in long term in patients due to the risk of serious long-term side effects and complications.
Yeah. And in terms of the rate control strategy, what are your preferred first-line medications, or what works best from practice?
I tend to start with, if LV function's good, I tend to start with a beta blocker, but a rate-limiting calcium channel blocker is also fine. And I quite like digoxin as well, so the combination of these three. The ASC guidelines suggest that we don't need to be so strict with heart rate control. So sort of moderate heart rate control, is just as good, providing the patient's symptomatic. So there are the three drugs that I would use for rate control. Just a quick comment on ablation. I've not mentioned ablation much. I would normally offer ablation to an AF patient that's failed an antiarrhythmic drug. The guidelines suggest that you can offer it first line, but I would always be cautious and always involve the patient fully in the discussions. As I mentioned before, talk about the procedural success rates, talk about potential risks and complications. And my practice is usually to go with an antiarrhythmic drug in the first instance, and try and modify as many of their cardiovascular risk factors as possible.
Yeah, thank you very much. That's a great summary again, and we kind of touched a bit about some subgroups, as you said, patients with risk factors, the elderly, frail patients. Are there any other subgroups of patients that we should think about or have some special aspects to their AF management? Valvular heart disease, or is this more specialist input?
No, I think the one group that I would probably focus on is the elderly and patients with the highest chance vascular risk scores, because they've got the most to gain from anticoagulation. but often to me seem to be the ones that turn out not to be anticoagulated for a variety of reasons that really aren't firm contraindications. Now, obviously, if you give an anticoagulation, an anticoagulant to a patient and they have a major, catastrophic bleed, then that is a disaster. But is it better to let them just have an ischemic stroke from AF? Well, no, it's not. So I think we need to identify the patients that we are inappropriately withholding anticoagulants from. And these are often patients with the highest CHA2DS2-VASc scores, the elderly. They often have the highest bleeding scores as well, but that's just life. And informing the patient, and their relatives about the pros and cons of anticoagulation. And I mentioned fall. So a lot of elderly patients aren't anticoagulated because of the potential risk that they might fall or they do fall. And the ESC guidelines suggest that a patient needs to fall about 300 times a year for the risk of falls to outweigh the benefits of anticoagulation. So I think that's an important point. An important point that we need to, the patients at highest risk, we really need to have discussions about anticoagulation. A couple more specific points. I mentioned amiodarone in the elderly is perfectly reasonable. And finally, in elderly patients with difficult to control or highly symptomatic AF, a pacemaker along with an AV node ablation can be a really effective treatment, especially if a patient has side effects to medications that they don't want to take. They obviously need to stay on anticoagulation if that's indicated, but that can be a really, really effective treatment for some highly symptomatic patients.
Great. Thank you very much for your time. I think we managed to cover some very important aspects in the management of atrial fibrillation patients. And I guess we've already summarized the main key points. Is there any other messages you want to give to all those doctors looking after patients on the wards that you think we didn't cover?
Well, I think we've covered most. I think we've covered most of the important points. I like the ESC's ABC: anticoagulate or consider patients for anticoagulation. That's so important and done early. Don't delay over that. CHA2DS2-VASc score is pretty straightforward. Symptom control by whatever means, and I would involve your local cardiologist or electrophysiologist if needed. Finally, and I've emphasised this through our discussion this afternoon, it is really important to modify risk factors, especially weight, blood pressure, alcohol intake, etc. So I guess these are my ABCs, really my take-home message. And thank you once again for inviting me to chat to you this afternoon.
Thank you, Dr. Stirrat, for your time and for this overview of the new guidelines on the assessment and management of patients with atrial fibrillation. We hope you enjoyed this episode of Clinical Conversations and found it useful. We have an exciting week coming up at the Royal College of Physicians, Edinburgh. The online 60th St Andrew's Day Symposium will be happening from the 24th to the 27th of November. This year we have 4 days of interesting talks and discussions on a range of topics, giving an update on acute medicine. The online booking system is still open. We hope you can join us and enjoy the programme.